Okay. Hello everybody and welcome to PMDD and Me Meets the Professionals with Asarina Pharma. My name is Alice Girling. I'm a fellow of the Higher Education Academy and I'm a registered midwife with a specialist interest in reproductive mental health. I also have my own lived experience of treatment-resistant PMDD, which I lived with for over 20 years before taking the difficult decision 4 years ago to have a total hysterectomy. PMDD and Me is a community interest company that Sarah and I co-founded 2 years ago. As a CIC, we reinvest money back into the PMDD community and deliver you the highest quality of evidence-based education so that those experiencing menstrual mental health and menstrual disorders to enable themselves to become their own advocates and to be self-empowered. So I'd like to welcome you to the first of PMDD and Me Meets the Professionals virtual tour. This is an exclusive series in partnership with Asarina Pharma, where we bring you leading PMDD and reproductive health specialists together in an accessible and engaging format so that you are empowered with education and can become the expert of your own condition. Today, we bring you the specialists from Asarina Pharma themselves. So I'd like to welcome Karin Ekberg and Professor Torbjörn Bäckström, who have undertaken extensive research into PMDD and the now well-known drug trial, which led the way in being a targeted treatment for PMDD, has now completed phase 2 trials, which showed highly unexpected results. So today is a chance for PMDD and Me and Asarina Pharma to go through the top line results and give you a chance to ask us questions to explore what comes next. So I'm just going to welcome our panelists. Bear with me one moment. Karin, can you hear us?
Yes, I can hear you nice and clear. Hello.
Hello, welcome. Would you like to introduce yourself and Asarina?
Of course. Thank you so much, Alice, and your team for arranging this webinar, first of all. So my name is Karin Ekberg and I serve as the COO at Asarina Pharma, and I have been working at the company since we started it. Maybe I should just start by saying a few words on the company.
That would be lovely.
It is a Swedish biotech for developing Sepranolone, and we founded the company in 2006. And since 2018, we are on the Nasdaq First North in Stockholm, the stock exchange. But we are still quite a small company with only some 10 to 15 people involved in the development. The company is based totally on 40 years of research from Professor Torbjörn Bäckström and his group in the University of Umeå, with the focus to better understand the influence of the central nervous system by endogenous or natural sex and stress hormone, what they do on the central nervous system. In particular, Asarina focus on allopregnanolone related stress and mental related disorders. So Sepranolone is a so-called first in class. It's a new compound, a new family of compounds. We call them GAMSA compounds because it's an abbreviation for GABA-A receptor modulating steroid antagonist. Horrible. GAMSA. Maybe not so nice either, but that is what it is. And these GAMSA, in particular Sepranolone, we know can inhibit the action of alloprenolone on the GABA-A receptor. And Professor Bäckström will give you a short presentation on PMDD and also the mode of action for Sepranolone. And after that, I will, of course, present the first data we have for the study. And thereafter, we are happy to answer any questions that you may have. So why don't we hand over to Professor Bäckström first?
Lovely. Professor.
Yeah, okay, thank you very much. It's nice to be here and be able to speak to you all. Perhaps I could have the slides. Who is going to?
I will do that. I share my screen. So now I hope you see the slides, everyone.
Yes, could you move forward to, well, this one, yes. I would like to present myself a little bit. I'm a professor in obstetrics and gynecology, but my main specialist is reproductive endocrinology, and I have been working with the steroid hormones, and stress and sex hormones, and their effect on in the brain. And we started in the early 70s, so we have had a quite long time doing this kind of research. We have also developed a lot of new knowledge concerning the effect of these steroids in the brain, and we also found, which was quite important, that these steroids are very potent activators of the GABA-A receptor. And the GABA-A receptor is the major inhibitory system in the brain, and I will talk a little bit about that shortly. I have also to say that we are also, I am also the founder of Asarina Pharma, and of course I have interest in the fact that Asarina Pharma is developing these compounds as they are more or less my babies. Okay, could I have the next slide, please? First, I would like to share with you some knowledge about the menstrual cycle. The menstrual cycle is a very, very precise and regular cycle. It's divided in two phases: the follicular phase, which is the first part of the menstrual cycle before ovulation. But after ovulation, there is a development of a corpus luteum, a yellow body, in the same part of the ovary where the ovulation actually occurred. And this yellow body, this corpus luteum, produces progesterone, which is one of the major hormones that are needed for a continuing of the continuing of the pregnancy. In parallel with progesterone, there is also production of estradiol, which is the other sex hormone, which is of need for the pregnancy, but it's also of importance for being the one of the active compounds in the brain. The ovulation signal is actually the LH surge, and the LH surge is a result of an estradiol increase, and this LH surge will tell the ovary that now it's time to do an ovulation, and that is the reason for this LH. Follicular phase hormone, FSH, is the one that actually stimulates the ovary to produce these bodies in the ovary that actually ovulate in the mid-cycle. Well, anyhow, the problem with, if we could have the next slide. The problems, of course, in relation to PMDD is very diverse in that way that many women do experience menstrual cycle linked symptoms. And there are up to about 150 different symptoms which have been described to show a cyclical pattern during the the menstrual cycle, but the mental symptoms in relation to PMDD and PMS are the most common one. And about 50 to 80% of women can feel some kind of changes during the menstrual cycle, but usually to a low severity and no impairment. About 22 to 26% show a more severe condition, and about 3 to 8% have this very strong negative mood changes in relation to the menstrual cycle, and that is the PMDD condition. Could I have the next slide, please? What we also see is that PMDD is actually has a genetic disposition. There is a higher incidence among twins, the identical twins, and especially in relation to mothers and daughters. Both seem to have PMDD very frequently. That means that a quite high number of individuals, both in Europe and US, or in fact all over the world, are suffering from these negative mood changes, which are related to the luteal phase of the menstrual cycle. The next slide. The diagnosis of PMDD is now settled, and today there are two different very important views that are being shown. It's one by the American Psychiatric Society, which have made a diagnostic manual for mental disorders called the DSM-5, and PMDD is included in this diagnostic manual. However, WHO did a new diagnostic book, ICD-11, in May 2019, and this includes also PMS or severe PMS or PMDS. It's called a little bit different, as a gynecological disorder. And the reason for including it as a gynecological disorder was that WHO admitted that it was actually caused by some kind of provocative compound that was coming from the corpus luteum of the ovary. And by that, it means that it is a psychoendocrinological disorder, and not a pure psychiatric disorder. So that was an important step in the development of the diagnosis. The diagnosis is very strict, and it requires from the patient that they do daily symptom ratings, at least in 2 menstrual cycles, and that they have significant symptoms in at least in 1 week before the menstruation, and the cardinal symptoms are depression, anger, irritability, anxiety, but there are also some physical symptoms like breast tenderness and bloating. That's the most common symptoms. And in addition to this, there is a demand that the symptoms should be also of some severity, or there should be some impairment of the symptoms in the individual. So could I have the next slide, please? Here we see a picture showing the impairment per day during the menstrual cycle in 55 consecutive patients, unselected, who were consulting for PMS and PMDD at our gynecological outpatient department. And you can see that even in this unselected population with different severity, there is a quite high number of individuals that have a fairly long impairment of their own situation, the family situation, the social life possibilities to do social life, and it affects also working capacity. So it's no question that even in such an unselected population, there is impairment per day. But if we look at the next slide, we can see that in the patients with PMDD diagnosis, this is much worse, and you can see that the impairment occurs in about 10 to 12 days for themselves, for the family, for the social life, their social life, and also in 25 to 50% of the individuals, it affects the work and their possibility to function at the work. So it's no question that it is a devastating condition and a disorder that needs a treatment. Could I have the next slide, please? In this slide, we see the symptom variations during the menstrual cycle and how they relate to the hormones produced by the corpus luteum of the ovary. You can see that two hormones, progesterone and allopregnanolone, they are both produced by the corpus luteum of the ovary, and they increase shortly after ovulation, which is in the middle of this picture. And thereafter, there is this development of the negative symptoms here exemplified by irritability and depression. And you can see that they increase with a maximum during the last 5 days prior to the onset of the menstruation. And when the full flow has started, the menstrual full flow has started, the symptoms usually go away and are gone within 3 to 4 days after the onset of the bleeding. And this, of course, indicates that there is some kind of symptom-provoking factor being produced by the corpus luteum of the ovary. And could I have the next slide? And this is further proven by the fact that in anovulatory cycles, in cycles where no ovulation occur, no corpus luteum is being produced and no corpus luteum develops and no allopregnanolone is being produced. And in these cycles, there is no increase in negative mood symptoms in the premenstrual period. And this slide shows actually a number of patients. I think it was 12 patients in which we had one ovulatory cycle where they show this typical cyclical pattern, as you can see in the slide, and one anovulatory cycle where we could prove that they had no progesterone production or no allopregnanolone production. And in this anovulatory cycle, the symptoms disappeared. And this has also been replicated by using preparations, medications that inhibits the ovulation, and there are available certain such medications which can be used. However, they are a bit difficult and not approved for this indication. Could I have the next slide? Another proof in this is that what is then the symptom-provoking factor? Well, it's well known that in certain individuals, oral contraceptives and other steroids can induce negative mood symptoms. And because of that, we made a study in postmenopausal women needing HRT, hormone replacement therapy. And in this, we gave them progesterone, and progesterone orally and also vaginally, if we do take it vaginally, is metabolized to allopregnanolone. So it's actually allopregnanolone that we are giving. And in these situations, they developed the negative mood symptoms, which you can see in this slide. And if it was a placebo, they did not develop these negative mood symptoms. And the decrease in the beginning of this cycle is due to the prior treatment cycle where we gave both the placebo group and the the patient group or the treatment group, the negative mood inducing progesterone. So could I have the next slide, please? Well, the background and the, let's say the target in the brain is the GABA-A receptor. And the GABA-A receptor is a very common receptor. It's actually one of the most common receptors in the brain. And it also is, you can find it in very many different configurations and shapes. And here we show 3 different shapes of the GABA-A receptor. The GABA-A receptor is also a target receptor for many compounds which are well known, for instance, barbiturates, benzodiazepines, and alcohol. So I suppose that many of you have tried this, the compounds that are active on the GABA-A receptors. But neurosteroids, and especially allopregnanolone, is also a very potent activator of this GABA-A receptor. And the GABA-A receptor, as I may have said, are located in different areas of the brain, and you can find about 20 different forms of these receptor subtypes in the brain, and they are located in different areas of the brain, and by that they are also acting on different conditions depending on the subtype and the area. For instance, alpha-2 is related to emotions, and alpha-4 is also related to emotions, and they are located very much in hippocampus and in amygdala. The alpha-4 is also in thalamus, and it's also related to movement disorders. Alpha-5, however, is related to a part which is called hippocampus, and that part is related to cognition, memory, and learning, and that is also of interest in this area. Could we have the next slide, please? We know that what allopregnanolone does on neurons is actually to increase the opening of this GABA-A receptor. And the GABA receptor is a chloride channel, meaning that when it's open, it actually releases chloride into the cell. And as you can understand, if the channel is open very long time, then of course more chloride will enter into the cell, and that will also give some kind of effect, like it's possible to induce anesthesia with allopregnanolone, in fact. And could I have the next slide? And what we know that sepranolone does is that it actually normalizes this effect of allopregnanolone. So it counteracts the effect of allopregnanolone, and by that it also normalizes the situation in the brain. That is the action of this. But what is the beauty of sepranolone is that it has no effect by itself. So if allopregnanolone is not being present, or any of the other compounds that are similar to allopregnanolone are present, nothing happens. And that is very important, because that decreases the number of side effects that are possible to be induced by sepranolone. So therefore, we have also seen that there are very few side effects of sepranolone. And with that, I would like to give over to Karin to talk about the study that we have made now in shortly.
Thank you, Torbjörn. Well, so it was about 2 weeks ago since we received the first data on the study, but I should say it's only the top line results. So we only have sort of average from the different groups. There is still a lot more detail to be released from the study. But before I talk about that, I just want to say first that we did perform a first study a so-called phase 2A study in Sweden a few years ago. So this was our first study with Sepranolone in patients with PMDD. And the study included 120 Swedish women with PMDD. And this was also a randomized placebo-controlled study in which we tested Sepranolone for 1 month in an otherwise very similar way as we have done in the just recently completed study. However, another major difference, in addition to the treatment duration, was also that the patients actually came to the clinic for their injections in this first study. And the conclusion from the study was that Sepranolone was safe and well tolerated, and it alleviated the symptoms and improved the symptom-induced impairment on the daily life of these women. So the results were very encouraging. So now we have completed a so-called phase 2B study. And the aim of this study was, of course, to confirm the results from the previous smaller study. This slide shows you the design of this randomized clinical trial. This protocol included 3 cycles, menstrual cycles of treatment. The effect variable here is the symptoms reported by the patients in a diary throughout the study period. So before any treatment was given, the patient had to report their symptoms during 2 to 3 screening periods for verification of the diagnosis. And these data was also used as baseline data. If the patient's symptom recordings showed that she fulfilled the criteria for PMDD, she was then randomized into one of 3 treatment options, either of 2 doses of Sepranolone or placebo. And after completion of the treatment, there was also a so-called follow-up cycle. Torbjörn did talk about the diagnosis as such, and I can again just emphasize, especially in a study, we have to direct ourselves to what we call pure PMDD patients. So the diagnosis criteria are very strict. Essentially, patients have to be symptom-free, pre-ovulatory, and have them significant problems pre-menstruation. And this cyclicity needs to be present from patients' history in a majority of menstrual cycles. And the diagnosis also then needs to be verified in at least 2 menstrual cycles. And to the left here, you can just see a diary from one patient where each vertical line represents a day in her diary. And the dotted line is the first day of menstruation. And you can see clearly here how she has reported on 3 questions about depression, how the symptom decreased fast once the menstruation starts. Then she has a couple of days with basically no symptoms. Then the ovulation occurs and the symptom starts to increase again, up in this case to severe and even extreme in one cycle. And so this is a typical PMDD pattern. To assess this, we use a validated diary. There are different diaries, but the most commonly used are called DRSP. And this is quite an elaborate diary. In this, there are 21 questions about 11 symptoms. So for example, the depressive symptom is asked by 3 questions, as we saw in the earlier slide. The first 4 symptoms are the so-called cardinal symptoms, or core symptoms. And this is because it is a prerequisite for the diagnosis of PMDD that the patient present with at least one of these symptoms. Then there are a little bit more unspecific symptom questions. For example, if the patient experiences less interest in usual activities during the day, have concentration difficulties, increased appetite, difficulty to fall or stay asleep, or feeling overwhelmed or out of control. And then there are 4 questions about more physical symptoms, like, for example, headache. Then in addition comes the 3 questions that relates to impairment, on how the symptoms affected the patient's day at work or school or whatever she's doing normally. And if it interfered with her hobbies or social activities, or if it interfered with her relationship with others. So the primary endpoint, the primary effect variable in the study is the total symptom score. You sum up all the first 21 questions and then look at the change from baseline to doing treatment, and you compare that in placebo and active group. And this is something that we have, of course, discussed with the medical agencies like the MHRA in the United Kingdom, for example, or the FDA in the United States. And we have to sort of follow what they want us to do. And just to look at the total symptom score, this is again a representation from one patient's diary, and where the sum of the 21 questions are depicted here. The red line, vertical line, is the first day of menstruation, and the F days, the yellow ones, is before ovulation, and then symptoms reoccur, and we assess them when they are the highest in the green panel here, depicted in the green panel. So these are the highest scoring during the day -6 to 1. So to assess the effect of Sepranolone, there are like 4 key metrics to look at, or 3 actually for the effect. First, it is the primary endpoint that the regulators want us to do. And that is the sum of all the 21 questions. And the statistical difference here, of course, need to be driven by what we think is the most important, and that is the cardinal symptom, the core symptoms. So we have used those as a secondary endpoint. And then in addition to that, a secondary endpoint is the impairment score, the 3 questions on how the symptoms affected the woman's daily life during the day. And then in addition to this, of course, safety is always a very important thing to look at in the study. So let's now turn to the actual patient population in the study. In total, we enrolled 476 women into the study, meaning they got information about the study, and they signed an informed consent, and then they started screening in the diary. But as is the case in all studies in PMDD, many women don't meet this strict criteria, and 270 women were therefore terminated during the screening period. So that left us with 206 patients that were found eligible and were randomized to either of the 3 treatment arms. And the patients randomized, they were distributed among 12 clinics in 4 countries. As you can see there to the left, in Sweden, United Kingdom, Germany, and in Poland. However, 4 patients randomized did actually not start treatment after all. They withdraw consent or something happened. I know a father died, for example, to one of the patients. So eventually 202 patients started treatment. Then for the actual population where we assess the effect, it's called an intent to treat population. There was a prerequisite that the subject had at least 1 full completed treatment cycle where she had taken at least 4 doses or had evaluable ratings. And the cycle needs to be ovulatory also, which we assessed with the progesterone sample. So the effect population, which we assessed in the ITT population at the end, became 192 patients. These were then distributed fairly equally between the 3 treatment groups. This was of course done completely blinded, but this is what it looked like when we opened the code. So you can see there were 63 women in the lower dose of Sepranolone, 62 in the higher dose, and 67 in the placebo group. And during the period of treatment, we had between 8 and 10 dropouts during the treatment. So at the end, we had 55, 54, and 57 women that completed all 3 treatment cycles. So in summary, we can say that 80% of all patients treated, the started treatment, actually completed all the 3 treatment cycles. This is very good for a study such as this. These patients were on average 35 years of age and were normal weight. They had a BMI of 24. So in total, we have here 547 menstrual cycles evaluated. And at baseline, they were on average 28 days, which is the normal length of a menstrual cycle in an average population. And also the variability between cycle lengths was as expected. 90% of the cycles didn't vary more than 4 days. 6% of the cycles during the treatment were anovulatory, or we couldn't confirm on ovulation. Sometimes the progesterone sample wasn't taken in the right time and so forth. And we have a sort of demand to not include those cycles because that would be a sort of false positive data. So therefore better to take them out than to use them. So we don't overestimate an effect that's not there. So overall, we think we collected a very good sample and data for the assessment of Sepranolone. First, a little bit on the actual drug product. So it is a product for subcutaneous injection under the skin, similarly as in a diabetic taking insulin. So it's preferably taken on the belly, as in the picture, down to the left. And the formulation was filled into small syringes, 0.4 milliliter. And these syringes have a fine needle integrated, so it's as easy as possible to use. And we tested then the 2 doses of Sepranolone, 10 or 16 milligrams, that the patient injected at home by themselves. So they started the treatment estimated 14 days prior to next menstruation, and then took a dose every 2nd day during the luteal phase until menstruation start. But we allowed only 7 injections maximum in the cycle. So to the right down there, you can see the red dots in one patient diary where she has reported taking an injection. In total, more than 3,000 doses of Sepranolone or placebo has been taken in the study, and the experience from this have been overall very good, and really no safety concerns reported. In 85% of the cycles, there were 6 or 7 injections taken, also at an appropriate time as intended in relation to the patient's menstrual symptom peak. So again, we are very happy with the compliance of the patients. They have been fantastic in the study. So first, let's say something on the safety. We had no serious adverse event reported in the study that were relating to the study medication. And for those of you who know how a clinical study works, we divide events in serious, which is the sort of definition. For example, someone dies or comes to hospital or so, or other adverse events, but no serious adverse events reported related to the study medication. In total, we had 236 possibly related adverse events reported. So that could be either to Sepranolone or placebo. And the vast majority of these were mild and transient, and none were severe. No single type of general adverse event, and I mean then like headache or nausea, occurred in more than 3% of the patients, and there were no overrepresentation in the Sepranolone group as compared to the placebo group. More specifically, the majority of these events, they were actually related to the injection site. These injection site events occurred in 20% of the patients. Again, vast majority of these were mild and transient, none were severe. So 80% of the patients had no reported problems by the injection at all. But some women are apparently a little bit more sensitive in the skin to the injection. And this is, I think, quite common finding in all injected products, basically. So in conclusion, we have no negative safety signals and generally well tolerated. So let's turn to the actual data of efficacy. So in this slide depicts now the baseline data during the diagnosis period. To the left here, you see the total symptom score, the sum of all 21 questions. In the middle, you see the cardinal symptoms. And to the right, you see the impairment scores. And just for a reference to understand these numbers, the symptom score was on average 85% points, and that corresponds to an average symptom of moderate to severe. However, then, when we look at the actual reductions obtained during the treatment, you can see to the left a set of bars that following Sepranolone, there was a marginal better reduction as compared to the placebo group for the total symptom score. So in the Sepranolone group, we had 30 points reduction, and in the placebo, it was 28 points. So, and you can see the pattern is the same for the cardinal symptoms as well as for the impairment score, unfortunately. So obviously, there is no statistical difference decided here between the effect in the Sepranolone group and versus the placebo group. And just to give you a comparison, again, to the left, you see the data from this study. We had a 38.2 points reduction in the placebo, in the Sepranolone group, and a 27.9 in the placebo group. To the right, you see the corresponding results from the phase 2A study. And you can see here the big difference between these two studies is the placebo effect. That was massive in this group. And therefore, the results from the study is inconclusive. We can't really say that Sepranolone is working, nor will we want to say that it's not working, especially related to the fact that we have other data showing its efficacy. If we also look into the different symptoms, as you can see here depicted, we have the same sort of pattern. Again, marginally better for the Sepranolone as compared to placebo. There are no statistical difference from these at all. And I picked it in here, the results from the phase 2A study, where you can see the stars indicates where we have a statistically significant defined difference between active and placebo, where we have the effect in basically the cardinal symptoms as we wanted, as sort of the most important to say. So this is, of course, a big disappointment for us and for everyone, I would say, right now. So if we conclude the study, the baseline data show that we recruited the patient population that we intended. We had stricter inclusion criteria in this study as opposed to the other one, so we had a really pure population of PMDD. Sepranolone was well tolerated with no negative safety signals observed. Sepranolone did, however, not meet its primary and secondary endpoint. The placebo effect was so high, there was also great variance in it, the spread between patients. And the change from baseline in the Sepranolone also were larger than expected. Numerically, the reduction was larger in the Sepranolone group, but the placebo group, but of course there is no statistically significant difference in these results. So why do we have this placebo effect? That is, of course, a very interesting thing to try to find out. And for the time being, we can only speculate. But first of all, we have to remember that the endpoints here are based on symptoms. So it's not really an objective marker. But I can also say to you that also in other indications where I've been working before, even if you have something that you assess objectively, like a measured blood sample, you also see placebo effects sometimes, but the magnitude is of course much smaller. Placebo effects are known from previous studies in PMDD, but it was much higher in this study than we had expected. And why was that? Well, first of all, I think we have great expectations from a novel new treatment, or potential new treatment, of course. And this is, of course, driven by the fact that many patients have not previously been diagnosed or acknowledged by healthcare providers. I'm pretty sure that Alice and team can talk much more on that. Other patients may have failed on other treatment attempts. But I think what's special here is also that we have an injectable drug product. And in general, we have a perception by all of us that injectable medications are real potent ones, aren't they? So you have a big expectation on the fact that this drug will really work. And moreover, of course, we had here a study where patients had to inject this themselves at home. And I think this, of course, made us have a population that was, of course, the real believers, the strong believers in Sepranolone, that were willing to do this and to participate in such an experimental study. So I think that may also contribute to this. And then, of course, it's also conceivable that a longer treatment period is needed to sort of adapt to the injections, to get used to them, so that is sort of weaned out. And also generally that the placebo effect weans out when you have a longer study. But again, these are only speculation and we can talk more about them afterwards. So in general, we hope that our research around allopregnanolone will play an important part in the collective understanding of PMDD. With 1.2 million clicks showing interest on our advertising campaign, we are proud that this study might have been valuable to raising awareness of PMDD in this, as Torbjörn said, really devastating condition. We really hope that we have at least contributed with that. We know allopregnanolone is a powerful neurosteroid and has a high impact, and there are women sensitive to the elevation of allopregnanolone. There is no doubt about it. It's just that we don't have an objective measure who is the patient that would really benefit from this as it is right now. Because we know Sepranolone reduces allopregnanolone-induced effects in the brain. And again, the results from this study are inconclusive and do not disapprove that Sepranolone may be effective in treating patients with PMDD. Now, as I said, Asarina Pharma is a small company, and for us, we will continue to develop programs of Sepranolone for menstrual migraine. Such a study is already ongoing. And we are also starting studies in Tourette syndrome. And I think for the future, I think that is the best hope we have right now, is that we are successful with the menstrual migraine program, and thereby the Sepranolone injections will be out on the market and then available for further research by the research community and the scientific community. So I think I will end there, and thank you very much for listening. And we are very happy to take any questions from now from you. Also, I hand over to Alice.
Thank you very much for that, Karin and Torbjörn. That was fantastic. I'm just going to bring you into the gallery view so we can just ask you some questions.
You want to stop sharing my screen?
Yes, that would be lovely. Fantastic, thank you. That was a fascinating presentation from both of you, so thank you so much for that. The questions were absolutely flooding in, so I'm going to go straight into them if that's okay with everybody. I wanted to start with looking at the drug family that Sepranolone belongs to. That was a question that sort of, the theme sort of cropped up quite a lot in terms of it being an injectable and what are possible alternative routes that it could be developed into in terms of what drug family it belongs to.
Maybe I can start answering on that. As a drug developer, I can first of all say that Sepranolone is a lousy drug molecule in the sense that it is very difficult to formulate into a functioning drug product. It is in fact an endogenous, a natural compound. It is the sibling to allopregnanolone. These are steroids, although they don't have hormonal effects directly themselves, neither allopregnanolone or Sepranolone. And these are both metabolites of progesterone. So they are part of the natural way for the body to excrete progesterone. And the way the body is doing that is normally, or there are different ways, but one very potent or avidly used one is by the liver to actually hook up on a sugar molecule to the compound so that it becomes water soluble, and then it goes, we have the circulation to the kidneys, and then we pee it out basically by the urine. So that's the excretion of compounds. And that therefore we cannot really give Sepranolone orally.
Right.
Actually we can. It is taken up with the intestine very nicely, but the liver is metabolizing it directly. So only 2% comes out into the circulation as a sort of actively working compound. We have started, and we did start out with vaginal administration, quite frankly, and that is still a potential option, but it became quite tricky in the beginning to find a sufficiently working version. So we concluded that we have to go to injections to really test this. But yes, that's the reason.
Thank you for that. I've got a question about aloe and the effect in the brain. Somebody has asked, if aloe has this negative effect in the brain, why do not all women have PMDD?
Torbjörn, do you want to answer?
Yes, perhaps I should answer that. Well, it's $100 million question. We don't know why certain individuals actually do these reactions, but we know that several compounds that are active on the GABA receptor do show similar kind of what we call paradoxical effects. Like benzodiazepines, for instance, can in some individuals be anxiogenic instead of being anxiolytic. And alcohol, of course, is a very well-known compound that is causing aggressiveness in certain individuals. And that is a well-known problem in relation to domestic violence, for instance. And it's actually, let's say, a little bit similar in this situation. So it's a phenomena which is very well known and very well accepted. But why certain individuals then are sensitive to this paradoxical effect and why not other ones are, that's not completely known yet. But there are many studies going on in the world, especially in relation to brain imaging studies and fMRI studies, which are going to show, hopefully, what is the difference between those who react during the luteal phase and which don't react during the luteal phase. But there is a provoking factor. And that this provoking factor is related to allopregnanolone, we are quite certain about.
Lovely, thank you. That's really insightful. Which links to a question that has been posed regarding hypersensitivity to sound and touch and pain. Do you think that there is a link between allo and this?
Absolutely. Absolutely, that's the same. And there is many symptoms which are linked to this. There is another condition, for instance, called the acute intermittent porphyria, which we have a lot of up in the north of Sweden. And this is also showing the same kind of pattern as PMDD, and have this pain as the major symptoms, stomach pain.
It's really complex, isn't it?
Yeah.
Somebody has asked about benzodiazepines, which also inhibit GABA. Is this something that is related to allopregnanolone?
Well, benzodiazepine is a separate compound which acts on the same receptor, the GABA-A receptor, but it acts in a different binding site. So it's not actually related to allopregnanolone and so on, but the production of allopregnanolone can be made also in the brain itself. And this production can be stimulated by benzodiazepines in certain situations. So therefore, it might be that there is an interaction between allopregnanolone and benzodiazepines, but it's not so well investigated yet.
Mm. Do you think that any of this metabolism has any relation to our overall metabolism within the body?
Oh, difficult question.
I think maybe one can say that the system, for example, in the liver, they have a huge capacity. I know we metabolize things quite different. We do from individual to individual, but still there's a huge capacity, and I think we are not really at all at the limit of what we can do, and that would be a reason for symptoms like this. It's so, I mean, these are so old compounds. I mean, they are in all mammals basically. There's no
also
difference.
in fact in plants as well.
Mm.
Yes.
So they are very, very old structures as such.
Yes.
From
yes.
Evolutionary old.
Yes. What we can also say about let's say other mechanisms. There might be some other mechanisms within the brain as the production also can occur within the brain, and it seems to be stress related. So stress seems to be a factor that can enhance the negative effects.
Mm. Looking to the study in a little bit more detail, we've had a few questions about the screening of some of the women. Somebody was asking about whether any vitamin D levels were checked prior to recruitment.
No, it was not. And the inclusion criteria included, or exclusion criteria, I would rather say, that patients were not on any medication that prescribed or over-the-counter medication for PMS or PMDD to be part of the study. Yet, of course, it's all about reliability and telling the truth at the end, of course. No, it was not. But clearly, again, we have the top-line results, and we will now look into all that. What sort of medications were the patients on? You know, whatever factors we can try to think about, we will look into, of course, and see if we can see any pattern.
Interestingly, we've had a couple of queries about how Sepranolone had an impact on the physical effects outside of PMDD symptoms. For example, Ebony has asked whether Sepranolone affected sleep and whether that had any improvement in insomnia with any of your subjects.
Again, it is too early to say. I can only share the slide that I did with the different symptoms, but again, these are on the population. There can certainly be a subgroup of patients where we look at them who specifically had sleeping problems before. So clearly, when we have the full data set, we will do all these analyses. So thank you for the idea. We will certainly put that on our list.
We very much look forward to reading the study in its full write-up when it comes out.
Yes. May I say also in that regard that, I mean, there are a number of researchers still very, very interested in PMDD, of course, and Sepranolone, and they are also eagerly waiting, and we will certainly share everything with that. These are Torbjörn's old colleagues from way back. They are a small group of what we call key opinion leaders, and for sure we will do all we can.
Oh, that's fantastic to hear.
Yes.
Looking at your research methodology and the methods that you looked, they were certainly very rigorous and very externally valid, which was really reassuring to see. We have had a couple of queries about the sample size and whether this was reflective in other similar research in terms of drug trials in the sample size that you recruited.
Yes, I mean, there have been a couple of phase 3 studies before, for example, fluoxetine, Prozac, or also the oral contraceptive JAWS. And this study is very much copy of those, of course, because it is what the regulatory agencies want us to do. The number of subjects, of course, is always related to what sort of effect you expect. And in this case, the study was powered based on the previous data. And from that regard, I cannot see that the study in any way is underpowered. But again, as I mentioned, maybe especially with an injectable, it would have been beneficial to have a longer placebo-treated period. Although, of course, this also sounds very unethical to have, but maybe that would help in this case. There have been one study was 6 months placebo-controlled study in the past, and it was the first phase 3 program with fluoxetine, Prozac, back in early 1990s, and that study was very criticized because there was also a lot of dropouts in the placebo group, and the regulators were not really happy with the study. And since no studies have been more than 3 cycles long.
It is a very difficult balance, isn't it,
Yes.
to establish. It's very challenging. And I think when you look at the placebo effect being so strong in this case, it would have been difficult to continue the research given these top-line results. So I think it's very much understood why you had to come to the conclusion that you did. But with a population such as the PMDD community, with Sepranolone being that glimmering hope that had been so eagerly awaited, I think that placebo effect is so difficult to counteract, isn't it? We've had some lovely comments. For example, Gabriella has said she is very, very impressed that you have been discussing your non-significant results, and she wishes that more pharma companies did this. So some really lovely comments, and they are looking forward to seeing the research as well. We're getting a lot of comments such as that, which is really nice to see. Let's just have a quick look through. Bear with me one moment. So what I wanted to move on to next was the menstrual migraine study that you're progressing with, because often that is a comorbidity with PMDD sufferers as well. So I think that there will be a lot of ongoing interest from the PMDD community as well as the wider reproductive health community. Can you give us a bit of information about the menstrual migraine study and what's happening there?
Well, I can start to say that the study is running right now. It's performed in Sweden and Finland. It's about 75% recruited, but of course with the COVID situation, it has slowed down. So we had the expectation to have the study completed by end of this year. I think it will drag on a little bit into the spring. Torbjörn, maybe you could like to comment a little bit more on the migraine situation?
Yes, I'm sure you know that there is a condition called the catamenial migraine, meaning that it's very common that women with a severe migraine have an increase in their spells during the menstruation. So what that means is that the pattern of symptoms are a bit different than the pattern of in PMDD. And that, of course, is a reason why this study is slightly different compared to the PMDD study, even though the treatment is more or less the same. So it's a menstrual cycle linked condition, and there are quite high number of individuals that have a severe migraine that show this menstrual cycle link in their attacks, and it's actually these individuals that we are now focusing on.
That's really, really interesting, and we look forward to hearing more information about that as it comes out. So thank you very much. I think that's all the time we've got now for questions. There were many more, so if you're happy, I will forward them to you for you to maybe answer them when you're able to, if that's okay, Karin and Torbjörn.
Sure.
Okay.
That would be lovely. So thank you again for taking the time today to come and explain everything, your extensive research, your expertise, your experience. I think without all of that together, this trial would possibly not have gotten as far as it had. So I think the PMDD community owes you a great deal of thanks for that. So on behalf of us, I would like to say thank you. And thank you again for shedding so much interesting data on us today. I'm sure a lot of us will need to go back and re-watch this again to fully digest everything that you've presented to us today. So thank you very much.
And thank you, Alice, for hosting this. I'm so happy everything worked technically well as well. So that's great.
Yes. Thank you very much as well. And from my side, it was very interesting. I'm happy to be able to participate and to actually make the life of these devastating, of the women that have this devastating condition slightly better.
Thank you. Thank you.
Bye.
Bye-bye. So thank you everybody for joining us today. I'm sure you can agree that that was absolutely fascinating. I've learned so much from watching that, and I definitely am going to have to go back and rewatch all of this again. At PMDD Me, we are championing the research that Asarina Pharma have done and will continue to do in their work in menstrual migraines, because as I'm sure many of you know, it is an ongoing comorbidity with PMDD and is a hugely debilitating aspect of reproductive health. So I eagerly look forward to more research on that subject, and we will bring it to you as and when it becomes available. Please do send us an email with any questions that you may have that we didn't get to, and we will pass them on to the Asarina team as best we can. And we will also be sending you a link so that you can rewatch this again at your own time and be able to reabsorb all of the data such as we did. I think it's safe to say that Sepranolone is here to stay in one form or another. So I think that that is something we can be hugely grateful for. And I wish you all a very pleasant evening. I hope that you and your family are staying safe, and we look forward to seeing you on our next series of PMDD and Me Meets the Professionals. Take care, everybody. Bye-bye.